Risha is an associate professor in Division of Infectious Disease from Johns Hopkins University. She's having a distinguished career. Have training at the Spelman College, then a medical degree from Harvard, and also in public health. And she did her internal medicine residency at University of California in San Francisco. She has served as an HIV Prevention Trial Network Scholar and a Presidential Leadership Scholar. She got the Nickens Faculty Fellowship at the American Association of Medical Colleges, and she is the Vice Chair for Diversity, Equity, and Inclusion for the Department of Medicine at Johns Hopkins University in Baltimore. And her topic today is hepatitis C testing and treatment in Louisiana, a model for the national hepatitis C elimination through corrections. Go for it, Risha.
Thank you so much. Very excited to be here today. And I think this talk is a great follow-up to the talk we just had now to use as an example. So I'm going to talk about hepatitis C testing and treatment in Louisiana, a model for national hepatitis C elimination through corrections. Here are my disclosures. So my objectives. By the conclusion of this talk, you will be able to describe the impact of hepatitis C virus on minoritized and marginalized populations with an emphasis on individuals in the correction system, identify key elements of the hepatitis C elimination plan of the state of Louisiana, and discuss really the impact that HCV testing and treatment in corrections have on HCV elimination. So as background, we all know that HCV infection causes cirrhosis and hepatocellular carcinoma, and really until COVID-19, more mortality than the combined total of 60 nationally notifiable infectious conditions, really signifying the importance of working towards hepatitis C elimination by 2030. But the question is, how do we get there? We know that HCV infection distribution varies and that there are certain populations that are highly impacted. Some of those are, as mentioned in the last talk, individuals with substance use disorders, people of color, individuals with interactions with the correction system, and people living in poverty. So if we think about justice populations, we have to think about the full scope of justice populations. That includes incarcerated persons, individuals in pretrial detention, individuals on probation and parole. And if we really want to move towards hepatitis C elimination, we'll need to do work in all of these areas. Today, I'm going to focus mostly on individuals who are incarcerated because I'll be talking about the project in Louisiana. So what we know across the US, and I think was really highlighted in the last talk, was that there are about 1.3 million persons in corrections with chronic HCV infection. In about 2018, it was estimated, out of about 2.7 million people overall. So we see a high burden of disease in our correctional system. So there's really no way to get to hepatitis C elimination without going through corrections. We also know that the majority of persons with untreated HCV infection in the US are associated with the correctional medical system, and that we know that people are at an elevated risk of transmission upon release as well. In Louisiana, we know that about 95% of persons in either state or local settings in correctional system will be released to the community. So it's really important to have hepatitis C testing and treatment in corrections to lower viremia and transmission in corrections, but also in the community as well. They work hand in hand together. And so this diagram is really meant to show just intersectionality. We know that incarcerated persons are disproportionately impacted by poverty and substance use disorders. And we know that persons of color, in particular African Americans, are incarcerated at a higher rate, as was emphasized in the last talk. This has really been due to the criminalization of substance use disorders and kind of drug use, and also an intersection of people living in poverty. So all of these factors really come together to really lead to an increase of hepatitis C infection that we see in incarcerated persons. And so this slide looks at the continuum of HCV care amongst the incarcerated persons. And again, what I want to highlight is the year of 2018. And so what you'll see, about 1.3 million persons or so have HCV. About 36% of those were aware of their infection. Only about a few of them had 5% had received treatment, and then about 4% were actually cured. If we maintain the status quo, what we know is that by 2030, only about 17% of those individuals would actually be treated in incarcerated persons. And so that's not going to get us towards hepatitis C elimination. So we've got to do more. This image here shows the Supreme Court case that the Supreme Court would not hear from a group of individuals in Tennessee who were trying to gain access to hepatitis C medications. And so the question has to become, and again, highlighted some in our prior speech, what are the barriers to treatment in incarcerated persons, and why would departments of corrections withhold treatment? And we know a lot of that is contingent upon this financial barrier, that there are limited budgets within the Department of Corrections, and that they're trying to treat a host of diseases with an aging population, and that we've had so many people incarcerated in the US. And so it just becomes very hard in a management of what those budgets are, and that's the reality of things. And because treatment has not been available due to kind of the financial issue, testing has also not occurred in correctional systems, because why test if you can't treat individuals? And so there's been kind of this disincentive to launch any type of hepatitis C testing and treatment programs in corrections because of this financial barrier. So this is where I get to kind of Louisiana and what they did. So Louisiana recognized this financial disincentive to HCV testing and treatment and decided that they wanted to do something about it. I've had the pleasure to work with their team since 2018 on their initial financing plan, also on their plan to train providers to treat HCV infection, and then to layer on research on top of their public health implementation project that would ultimately take place in both corrections and Medicaid. So back in 2016, they estimated that they had about 50,000 persons in Louisiana that had chronic HCV infection. And they knew that most of these individuals, the data that they had, were in corrections and were impoverished individuals, which is why they decided to focus their plans within Medicaid and corrections and really launch this hepatitis C elimination plan and what they call Hep C Free Louisiana. And the goal is really to meet hepatitis C elimination metrics. And when they looked at their data prior to the launch of this plan, they saw that only about 3% of people in Medicaid and corrections that they had on file had actually been treated for hepatitis C. So they knew they needed to do something that would really transform their system. So transformational change. And they came about that through the modified subscription model, where they capped their cost in terms of their direct acting antivirals. They were spending over $30 million a year on direct acting antivirals, but very few people were actually getting treated. So they saw that by capping their cost and launching this modified subscription model that I'll go into a little bit more recently. And that was the hallmark of their plan. But that wasn't the only part of their plan. And so do want to look at their other elements of their Louisiana hepatitis C elimination plan so we can think through all the things that need to be done to really work towards hepatitis C elimination. So they established this modified hepatitis C medication subscription model in both Medicaid and corrections because they recognized that these were priority populations. They wanted to educate the public on the availability of cure and mobilize these priority populations for screening, expand HCV screening and expedited linkage, to strengthen HCV surveillance, to expand provider capacity. And so they knew that they didn't have enough providers to treat in the community, which would also be important in terms of linkage to care when people were discharged from either state correctional facilities or their jail facilities. And then to implement harm reduction, complementary treatment strategies, and then finally to extend elimination efforts to all populations with the state. So again, starting in Medicaid and corrections, and really to want to expand beyond that as well. So in terms of this financial model, so really this looks at the elimination of this financial barrier, this disincentive to testing and treatment. So their structure, they had an open call for applications, and a lot of work went into developing this plan with kind of legal teams. And essentially, there was an open call for applications, and then an agreement was struck where you pay the manufacturer for unlimited access to soft bell for a set annual cost over a set contractual period in both Medicaid and corrections. So really kind of a revolutionary model, really first in the nation to kind of launch this type of model. And they set it at their annual expenditure cap. Within Medicaid, they used the negotiated price of the federal drug rebate program set up to the cap, and within corrections used the 340B drug pricing program as well. Now, the reason I think that something like this works is because it aligns everyone's incentives. And so everyone gets something out of it. If you look at the state, they get predictable costs, this dramatic increase in access, and really an opportunity to do a public health good to eliminate HCV. For the manufacturer, they get a preferred drug listing, a direct gain in both Medicaid and corrections, and the hope that this would also spill over into the private sector. And then for the people of Louisiana, it's really thinking about decreased morbidity and mortality and really increased cure rates. So kind of a win-win situation for all the parties involved. And so now I want to walk you through kind of what was going on in corrections in Louisiana and then where we've been able to go due to the hepatitis C elimination plan. So back in 2000, they actually launched their hepatology clinics. There are 8 state correctional facilities, and 3 of them had the hepatology clinic on site. They were treating with interferon-based regimens at that time. And incarcerated persons not housed at those sites were able to be seen by teleconference. Treatment was obviously limited by the side effect profile of medications and low cure rates. And then treatment was limited to F2 or above, which was in line with their Medicaid guidelines at the time. So direct-acting antivirals came along, and we all know that was a game changer in terms of cure rates, but they were expensive for their Department of Corrections. And so there was really very limited access due to the high cost and just the implications for their DOC budget. And it was limited to people with advanced cirrhosis or really had to have another medical condition where they couldn't take an interferon-based regimen. And then they essentially had a monitoring program to monitor people that they knew had hepatitis C. There was also not a mass screening program. And so there were undoubtedly people with hepatitis C that they did not know because people were really only tested at this point if they had a medical indication for treatment. So then Louisiana launched their hepatitis C elimination program, and it was really a game changer for access. So back in the fall of 2019, they began expanded screening in their Department of Corrections population. This started in the 8 state correctional facilities with a plan to expand to a portion of jails. The Department of Public Health and the Department of Corrections kind of launched this initiative together. And then they also added on intake and exit testing as well for hepatitis C and linkage to care in the community. They launched an education campaign at the same time to talk to people about hepatitis C testing and treatment. And then they launched a cohort treatment model. So one of the things that had been hard was kind of treating a person here or a person there. But now they have a cohort treatment model where people across the 8 state facilities can start at the same time. And so it's much easier for the hepatitis C coordinator to track people along that care cascade. And then, as you all know, in March of 2020, the global pandemic began. And I'll touch on this later because it has impacted the program through multiple shutdowns of kind of the state correctional facilities to individuals outside to come in and do kind of some of the hepatitis C mass testing and kind of treatment protocols. But what I'll say is that the Louisiana team has really done a phenomenal job of keeping this going in spite of many different challenges with both kind of COVID-19 and many of the storms that have also happened in Louisiana. So this just shows some of the characteristics as we launched this, again, kind of a public health implementation project with research kind of layered on top of it to kind of study the program. Looks at some of the characteristics when we started the study, again, looking at people in the state correctional facilities and then their local parish jails. You'll see overwhelmingly male, overwhelmingly Black, average age of 44 in the state correctional facilities, 36 in the local parish jails. We had information that about 3% were HIV positive in the state correctional facilities. The average sentence length was about 40, almost 40% had from 0 to 5 years in the state correctional facilities and approaching around 86% in the local parish jails. Now, what I will say about their system, there are some state incarcerated persons that are housed at local parish jails in their systems. And so that also kind of skews their numbers a bit, but we know that jails have a lot of that rapid turnaround that was mentioned in the last talk as well. And then if we look at time served amongst the state correctional facilities, approaching 11 years and around 2 years for the local parish jails. Now, what I will also say is that when this launched, there were about 15,000 persons in state correctional facilities and about 16,500 or so in the local parish jails total. During COVID, many people have been released due to kind of infectious disease protocols. And so both now are hovering around about 13,000 in both the state correctional facilities and the local parish jails. So wanted to talk about kind of the research that we've layered on top of this public health implementation project. And so our first aim, which we are now completing, is to characterize the dynamics of HCV infection in the correctional system among co-infected and mono-infected incarcerated persons. In this aim, we're looking at kind of HCV antibody prevalence in the correction system, because we really wanted to first characterize kind of everyone who's been impacted by hepatitis C, both those with current infection and previous infection. We're also comparing that to some estimates in the community and looking at some transitions between correctional facilities and the community as well. In AIM 2, which will launch this summer, we'll be assessing treatment impact as the trajectory of decline in HCV viremia among HCV antibody positive incarcerated persons and whether this trajectory differs between those with and without HIV. So really tracking how viremia goes down as they launch their HCV elimination program. We'll be doing some additional surveys to get more information on kind of substance use disorders as a part of this work, and then doing some community sampling as well. And then finally, AIM 3, which will use kind of data from AIM 1 and AIM 2, will be our modeling aim, which is actually being led by Dr. Natasha Martin out of UCSD, who is a part of the STOP-C study and kind of others that's looked at Hep C kind of modeling, and will disentangle the impact of correctional HCV treatment program on this HCV viremic decline and assess the impact of scale-up of correctional treatment programs on HCV incidence and mortality in Louisiana and elsewhere. And so what we'll be looking at in terms of kind of the modeling that will come from this project is really, are the observed reductions in HCV viremia among HCV antibody positive persons in corrections consistent with what we would have expected with intervention scale-up? What is the likely interim impact from 2020 to 2024 of the corrections HCV treatment program on incidence and mortality overall? And are the Louisiana treatment programs, both in the community and corrections, on track to achieve the Louisiana treatment goals and the WHO incidence and mortality goals by 2030? And if not, really, what level of farther scale up is needed? And so we'll be looking at those, and so really excited about what will ultimately come from this project. So now I want to walk you through some of the interim data that we do have. Things have obviously been delayed by COVID, but have been able to get some really good data out of Louisiana thus far. And really important for their Louisiana team was just getting a sense of prevalence, because we didn't know that at all. So just to show you what's been done, so there are 8 state correctional facilities. 6 of those have been completed. So they've gone in, offered testing to everyone. And then people are able to accept or decline testing, and then also have testing information coming in from intake and exit. So, right now we're hovering around 13,000 people or so total. 10,000 have been tested thus far. The last 2 sites that you see are actually actively in their testing program right now in the north of the state, which was kind of delayed for some logistical issues and due to COVID. So this is coming out of the 6 facilities that have been complete. And so what you see is that kind of there's a lot of variation amongst the site. LCIW is the women's facility here. The other are all men's facilities. And what you see is that kind of the highest here is 22% Hep C antibody positivity. And in that site, 14% had RNA confirmed as well. In our calculations, one of the things that we'll be doing is looking at obviously the data that we have coming in, but also looking at who missed or refused testing. Thus far, there's been about a 7% refusal rate, really for varied reasons, including just not wanting to participate, not liking needles, not wanting to wait in line, not wanting to miss a meeting with their attorney, with kind of their work schedule, with family, and then other reasons as well. But every individual is able to request testing at any time if they miss it for some reason or if they change their mind. And there will be follow-up at many of these facilities as well, but we'll account for this in our kind of final estimation of hepatitis C prevalence. I wanted to show this just so we could all think about the impact of hepatitis C treatment in Louisiana, but in Medicaid and corrections treatment, and the impact really that we've seen from COVID. And so what you'll see here is that about 100 persons per month or so were being treated prior to the launch of the modified subscription model. There was a lot of education and a lot of visibility around the launch of the model. So you see this up spike where it goes to about kind of 600 or so treatments being started per month in Medicaid. And this combines their Medicaid and corrections data. And that's really hovered around, anywhere from 200 to 600 cases. And you see the impact of kind of COVID here. A lot of that was due to kind of shutdowns of medical offices, shutdown of prison facilities. And so a lot of this kind of was delayed, but still a lot of great work has gone on, and you see kind of this sustained uptick in treatment despite COVID-19. Here, I want to just bring your attention to, we'll look at the corrections column just to show the characteristics of people accessing hepatitis C treatment. Again, you'll see sex at birth that 96% are male, as we would expect from kind of the population. The vast majority were Black. And here, if we look at kind of years born in the birth cohort, we see that we have a 45% in the birth cohort, but a significant amount of individuals who are younger than that as well. So I think, again, underscoring the importance of testing everyone so that we make sure that we don't miss people when we just look at different algorithms for testing. Here, I wanted to just highlight again that, Louisiana has really been able to make this work because they've used this cohort treatment model. And so essentially people are started and they're tracked through treatment all together. And it makes it really manageable for the staff and medical providers to manage hepatitis C care. This is one of the treatment cascades. And what you'll see is this goes from January of 2020 to the end of 2021. Now, what I'll say here, this is anyone who started treatment during this time period. So many of these people aren't necessarily eligible to have completed treatment or to have achieved cure at all. But you'll see that the vast majority were prescribed treatment. There are sometimes medication issues or people are discharged before their prescribed treatment, or there have been cases where people were diagnosed with a cancer that delayed them being put on treatment. You'll see that 92% as of this data pool had completed treatment, and then 67% were cured, but many of the individuals were not eligible in this data set for their cure check as of yet. If we limit it to an earlier period going through August of 2021, where everyone was eligible for their SVR check, then we see an 87% cure rate, but there's still a good bit that have been lost to follow up, or we don't have the data as of yet because some have been released to the community. And so there's a protocol to get that data back in the system, but all of that has not occurred as of yet. If we limit it to the individuals that we have SVR data on, right now on this data pool, we have a 91% cure rate. And so I think there are some important interim lessons that we've learned, that there's been high HCV testing and treatment uptake in corrections, that this cohort treatment system in Louisiana has made it really manageable for the medical providers and staff, and they've talked about that a lot, that it's worked well. And this was implemented with this hepatitis C elimination program. That HCV screening on facility entry and exit is crucial, and particularly thinking about kind of that discharge planning. But we do know that more resources have to be applied to correctional facility exit planning to follow up on HCV linkage to care in the community and to track SVR. And that's been one of the things that's been hard with this project. We would like for resources to be available to really give people their full treatment course if they're going to exit the facility. Right now, that's not done, but there are models in the US that are looking at that and doing that. And I think that's where we all need to move. Farther program expansion does have to focus on kind of jails and I think individuals on probation and parole, because we know that this is a continuum, and that if we really want to reach hepatitis C elimination goals, we've got to work across all of these populations that have a higher prevalence. I think in Louisiana too, this project is really valuable because it's really a public health implementation strategy. It's not just a research project. We've layered research on top of it so that we can gain information on the best practices and have kind of data analyzed and coming out of it, but really showing what a state can do in a relatively poor state in comparison to many others, what they can do with their resources when they mobilize and focus on a goal and try to align kind of their incentives to work towards hepatitis C elimination. But I do think we also have to acknowledge when we have kind of a public health implementation project, in research, we want every piece of SVR data. But, we do know that the vast majority of persons are going to be cured if they complete their treatment course. And then I think finally, the modeling from this project will be really valuable on HCV elimination metrics, and which can really help guide other states as well as they look at the Louisiana model. I did just want to mention quickly two other collaborative projects, because I think there's a lot of great work coming out of corrections. So our group is collaborating with Maryland to look at really the optimization of hepatitis C treatment models in corrections, and that will be discussed at our Maryland Hepatitis Summit. And I've put the QR code on the screen in case anyone wants to log on to that on May 18th from 9 to 1, which is fully virtual. We'll also have some of our collaborators in Rhode Island as a part of that panel. And their system is really unique in that it's one of just 7 unified correctional systems in the US where both jail and prison facilities fall under the same administrative and medical leadership. So they're able to really do a lot throughout the system. And, the issue that we have in Louisiana is that every parish jail is really under different leadership. And so it's working out something with each one of those parish jails. But in Rhode Island, they're able to kind of work the system together. And so we're looking at kind of HCV prevalence and then looking at treatment and pretrial populations discharged to the community. And they'll also be a part of kind of the panel that we'll have at the Maryland Hepatitis Summit. Again, just want to say thank you to everyone on the amazing Louisiana team who's worked really hard to see this work through, despite a lot of challenges as related to COVID-19, and then to NIDA and all of my collaborators on this project as well. Thank you so much.
Risha, I congratulate you for this spectacular presentation you gave. I think we are running a little short of time for the questions from the audience, and we will leave it for later on. But I have, since I'm the moderator, I have the privilege to have one question. And the question is, from all the 50 United States of the Union, what prompted you to do this fantastic project in Louisiana? And the second question is, why did they do so well? Because of Louisiana, or because of you, or because of the interaction?
Oh, well, I definitely can't take credit. I'll say, the reason that I got to be involved with their team is that there were other, Dr. Josh Sharfstein here at Hopkins was initially working with their team, Dr. Rebecca Yee, on their financing plan and providing kind of consultation on that. And I was invited to be a part of the project through Dr. Sharfstein. And then through that, I was able to work with them on that initial financing plan and then to advise them on their provider training program, which I had been working on for several years on kind of models to train providers, which initially got started in that work thanks to Dr. John Ward at the CDC, where we were looking at models to train primary care providers, HIV and substance use providers. So got to advise Louisiana on that. And then as they were launching and working with them on launching this in corrections and Medicaid, it was actually Dr. Thomas who said, I think that should be your R01. And so, met with them and worked out with them because I do think it's very important. They're launching a very large scale public health implementation project, but it's really important to understand what makes it work, what barriers they encountered, how we can improve, and then what lessons other states can learn from their work. And so it's been great to work with their team and kind of layer kind of research on top of their program that they have existing. I think that their program has succeeded because they have had individuals who are highly committed to this. The whole team at the Louisiana Department of Health and their Office of Public Health has been highly committed to seeing this through, despite many of them being kind of put on other projects during kind of COVID-19. And so they've been highly committed. And I would say that their leadership from their governor to Dr. Gee, who launched this when she was Secretary of Health as well, really wanted to see this come to fruition. And so having those leaders kind of take this on, and then also the Department of Corrections being a partner and saying, yes, we have to do this and get this done. And so they've had champions inside of their Department of Corrections as well. Excellent.
Congratulations again. And talking about champions, I'd like to now introduce the panelists.